Now, you also, I think, sort of both alluded to another group of patients that, quote unquote, you're a little bit worried about, right? I mean, you haven't proven that they're a Richter's transformation, but sometimes it's hard. The PET scans, the SUVs are a bit high, maybe the LDH is up, but you're worried. Is that a group that you're? I mean, I sometimes use R-CHOP in that setting. Is that what you're doing?
Yes, absolutely.
Right. I would agree. And there was some interesting data from the BC Cancer Agency at this meeting showing that for the patients that got bendamustine rituximab that relapsed within 24 months, 3/4 of those had transformation. So you wonder if there's a lot of, I'm sure we've had these anecdotes of folks that they got BR and all of a sudden we find out they had transformed disease. You wonder if the BR may not be it's clearly not as effective for treating aggressive lymphoma. So if there's any suspicion, high LDH, whatever, significant B symptoms, we usually use R-CHOP.
And you can certainly have reassurance that BR versus R-CHOP, there's similar overall survival. Sure, PFS is a benefit. So if there's any suspicion for large cell transformation and the patient can tolerate anthracycline, I think it really is kind of a no-brainer to give the R-CHOP in those patients.
There you go. Now we've had rituximab since, 97, I think, and it's been around, the first antibody to be approved for cancer therapy. And just when you think you know all about it, now we have this subcutaneous formulation of it. We're using it a lot in our practice. I think it's very popular with patients. I think it's popular with the infusion nurses. It gets people out of the chairs. Nathan, what's your experience?
So at MD Anderson, we have not quite adopted it as quickly, I think, as some of the other folks around the United States. I would say probably somewhere between 10 to 20% of our patients are now using this subcutaneous rituximab. But the drug is clearly, as you mentioned, easier to give with regards to how long patients have to be in an infusion center. About 6 to 7 minutes is the average time. Patients do have to be watched for 15 minutes afterwards. I find, at least in our practice, a lot of the barriers to subcutaneous rituximab are logistical. Getting the order sets, getting the nurses trained, getting the patients trained about the differences in administration. But my sense is, and I'd love to hear you guys' opinions, is that patients really like getting a shorter infusion and spending less time in the clinic.
Yeah, I would concur with that. I think in general, I can only think of one patient who wanted to switch back, and he had a bit of a local reaction, but most patients prefer it.
Especially when it's a single agent, right? Someone's just coming in and getting just that. They're in and out. I think that not only is it convenience, maybe it's psychological too, that you're not getting such an intensive therapy that you're tied up to the IV.
We've lots of randomized trials now in CLL, large cell, follicular, suggest that it's very similar when given with a chemo backbone. I do have some questions about how it will be used if we're integrating anti-CD20s with novel therapy. I'm not sure if equivalence with a chemo backbone means equivalence with lenalidomide, for example, or with a checkpoint or some other therapy. So I would like to see more trials combining a subcutaneous version with some of these other novel treatments before we would switch in all settings.
Let's switch and talk about a different antibody, Scott. Let's talk about obinutuzumab. So that, we've known the gallium data where obinutuzumab was combined with chemotherapy versus rituximab, and now we have some new data looking at minimal residual disease and progression-free survival. Walk us through some of that.
Yeah, sure. So, we had heard some preliminary data after a few years of follow-up that obinutuzumab chemo backbone had an improvement in PFS over rituximab with chemotherapy, chemo being CVP, CHOP, or bendamustine. It's on the update this year's ASH, 4 years. It seems like that PFS benefit is still there. Although it's somewhat early, the overall survival is important to note that there was really no difference between the obinutuzumab containing arm and the rituximab containing arm. In terms of other knowledge that's being generated from the gallium, I think it's been a very helpful study. They've looked at post-treatment PET-CT and the fact that Lugano criteria of scoring those PET-CTs can be quite predictive and associated with prolonged remissions. So I think there's more data from that. There's also data about MRD testing, which is coming out this year from the gallium, where effectively, the majority of patients, whether you're treating with our chemo or obinutuzumab chemo, are actually being MRD negative at the end of induction. What was really interesting is the majority of folks that, that sliver of folks that were still positive, maintenance typically got them over the edge and got them to MRD negativity. I think only 12 patients remained MRD positive, and those patients did quite poorly after short follow-up. It's also important to note that MRD seems to be equivalent in terms of what it means if you get R-CHOP or R chemo versus obinutuzumab chemo, in the sense that the MRD negative patients did just as well whether they had obinutuzumab containing versus rituximab. So I think we'll talk about MRD testing, but it's certainly an interesting clinical trial question, probably not ready for prime time, but it's nice to see that the gallium data is really giving us a lot of encouraging data, and not only in PFS, but also in some of the mechanistic and predictive properties.
All right, I'm going to put you on the spot here, and no one's getting off this question easily. So when are you using obinutuzumab versus rituximab?
Yeah, it's a great question. So if you actually look at the gallium, who are these patients? These were younger, a little bit younger patients. The median age was about 59. These patients also had high volume disease and were quite sick at diagnosis. So the one thing that surprised me when I presented it last year was that the median time from diagnosis of follicular lymphoma to treatment was just 6 weeks. That's not the typical patient that I'm seeing. I'm seeing patients and following them for years, and so I've selected obinutuzumab for those patients that are presenting with high volume, might be younger, fit, and are symptomatic, needing treatment right away. And in that situation, I sometimes will choose obinutuzumab. Oftentimes with CHOP backbone, I think the safety data might be a little bit more encouraging with obinutuzumab CHOP versus, say, a bendamustine based therapy.
What about you guys?
Well, I rarely use obinutuzumab. I'll just admit that. I would say I'm a skeptic of that trial a bit. I think I'm a little concerned that the milligram dosing was quite a bit different, and that might have driven things, and there was clearly more adverse events in the obinutuzumab arm. So when I sit down with my patient, with the rare exception of somebody that's very sick, and there are maybe some rare exceptions, but when we think about how do we relieve the symptoms that we're treating for, why we're treating, and think about the 20-year plan, I rarely pull obinutuzumab off the shelf.
Nathan, thoughts?
Yeah, it's very interesting how Scott kind of thinks about treating this. I have to admit, like Ajay, I generally don't do this in the front line. It's my go-to in relapse disease, especially rituximab refractory. But in the front line, I have not switched most of my patients. We do have ongoing studies with lenalidomide and obinutuzumab, and there we're seeing very interesting activity, and again, maybe due to the increased ADCC when combined with lenalidomide. And not as despite even long-term short/long-term follow-up of the early frontline trials, there is yet to be an overall survival advantage, which to me suggests that you could potentially use it in the second or third line setting and probably get to the same long-term endpoint, which is hopefully patients doing well.